magic point. So let's see, 5. The reason is because that's where the phrenic nerve is on most people. Most people's phrenic nerve originates up in C3 through 5. And the phrenic nerve is what, in addition to the brainstem being a problem for the higher ones, the phrenic nerve is what innervates what? Oh, it's right there, the diaphragm. So if you have no innervation to your diaphragm, you will also not be able to breathe, even if your brainstem is working. So, they also, for many patients with spinal cord injuries, will use the loss of intercostal muscles, their abdominal and thoracic muscles as well. And we need all of those to breathe effectively. So a lot of the rehab that they do is aimed at strengthening those muscles, because they may have some function if they don't have complete loss. And they will also use those muscles. Many people with high spinal cord injuries will use those muscles to learn how to speak again, believe it or not, where they kind of gulp air and then manage their abdominal and intercostals to let air up through their larynx to learn how to speak again. So, it's kind of cool. What are some, before we move on, I thought I had a slide there that had interventions, apparently I don't. So what interventions do you think we're going to use for patients with possibility of respiratory problems or with actual outright respiratory problems? What can we do as nurses?
Elevation of the head of the bed.
Elevation of the head of the bed to what? 30, 45. Not 90 necessarily, right? 90 is too high because it kind of cuts them right in the middle. They're straight up and down. But yes, elevation of the bed. What else?
Oxygen supplementation.
Oxygen if there's an order for it. What are we worried about with patients with long-term nasal cannula? Anything? Breakdown around their nose, as well as internally the nasal passages dry out and then they bleed and break down. So you need to be kind of careful. If someone's going to be very long-term, they might want to put them on a mask because they can put some humidity. You can't put humidity with a nasal cannula. What else? So we can sit them up, we can give them some oxygen. What else can we do?
Wrist respiration. We're gonna check the wrist.
Yes, you're gonna check your respirations and assess your lungs, absolutely. As needed and as ordered. Sure.
I think he said risk for aspiration.
Aspiration.
Oh, risk for aspiration, yeah, that too. That too. We're gonna check for if they're at a risk for aspiration, what are we checking for? Gag reflex. Now, don't get confused, that's the answer on NCLEX. But I'm gonna tell you something new so that you understand it. There is a lot of research that shows that a gag reflex is not enough anymore. That patients that have positive gags still will aspirate at a significant percentage. So, if you have a patient that has a gag reflex, but you still don't like how they're swallowing, your job is to talk to the physician and get a consult for who? Speech therapists. Speech therapists are the ones who do swallow evaluations. Do not ever feed a patient just because you have an order that says, feed the patient. Don't feed them if you think they're gonna choke and or aspirate. That is well within your rights, your obligations, your scope of practice, all that good stuff. Some places, nurses can order a swallow on their own, so just know your hospital policy. Okay, so Samir said aspiration, I said assess for respiration. What else? What's gonna help them to not have a lung problem or to improve?
Incentive.
Pull a mask down so I can hear you.
Incentive spirometer?
Incentives for honor, what else? No?
I was gonna say like respiratory therapists do the therapy.
Correct, respiratory therapists do cupping and clapping. Nurses used to do cupping and clapping, we have to stop giving away our jobs, and the only thing we're left with is charting, we have to stop doing that. Now they have techs doing also like crutch walking, no nurse teaches crutch walking anymore, so it's all done by techs. Anyway, that's a different speech. What else? Even though they're, go ahead. Cough and deep breathe if they can, absolutely. Anything else? How about turning and positioning?
If you can, yeah.
Right, well, right, if we can, and for these patients with spinal cord injuries, when we turn them, we wanna log roll them. We don't wanna be like, okay, I'll do the top and then I'll do the bottom by myself, no. Call for help, 2 or 3 of you, turn the patient in one swift motion. Anything else? Fluids. Fluids will help to decrease the viscosity of the, mucus in the lungs. So increasing fluids, and if they're at a risk for aspiration and they're not swallowing, then they should be on IV fluids so that they're maintaining their fluid status. Okay, so those are all good things that we can do on our own without an order, except for the speech therapy. Without an order, without intervention, without anything. Okay, we're gonna monitor it. Alright, so now that we did the interventions, we can move on to bladder dysfunction. When you have bladder dysfunction due to spinal cord injury or another nerve problem, it is called a neurogenic bladder. It's not that it's not working because of damage or because of a tumor, it's not working because the nerves are not working. So with all bladder dysfunction, the goal is to empty the bladder. And why do we want to empty the bladder and why do we care?
Risk of infection.
Risk for infection. If that urine stays in there, what happens? They get a UTI, and then once they get a UTI, then what happens? Right up to
Travel
the
up into
kidneys
your
and they'll have a
kidney.
pyelonephritis. Okay? So, because patients with spinal cord injuries can't often feel when they have to go to the bathroom, they physically can't feel it, that's what makes it a neurogenic bladder. Then we have to figure out a different way, or look for different ways to keep this bladder empty. There are 2 types of neurogenic bladders. The first one is, even though it says spastic, we're gonna do flaccid first. Flaccid is atonic, no tone, that's the empty balloon. It is areflexive, there's no reflex, there's no nothing. Nothing you can do about that. When they're not in the hospital and they're home in their own environment, or they're living in a care facility, they will often put in a Foley permanently. When you have that kind of Foley catheter in permanently, they get changed once a month, not every minute and a half. Okay? And the reason they can do it at home or in a care facility where they live is that the flora that their body is used to is what is surrounding them. They are not surrounded by strange people, strange flora, strange dirty hands because people are not washing them well enough, or whatever the case may be. Because I know in today's world, Foley catheter is it's like a curse word. It's like listening to Ricky Gervais. Bad. So, but in this instance, it might be the only choice. The other choice is to constantly have the patient wet, because this is the patient that is gonna constantly drip urine. They're gonna make urine, it's gonna fall out. It's gonna fall out, and they're gonna be wet, and then they're gonna get pressure ulcers in their labia and in their sacrum, and then it's gonna be even a bigger problem. So, if the option is to not, there is that third option now, there is the pure wick. There is a pure wick, which is for women. In men, we have a condom catheter, which is external. It's put on like a condom, it's attached to a bag. But in anything. But they now have PureWick, which is an external device that sits right next to the urethra externally, and it wicks in the fluid and collects it in a container that looks like a suction canister. So it basically is a suction canister, but it's a suction canister for urine instead of for secretions. So those are our options for flaccid, okay? You know, so, think about it, if someone's taking their family member home, they may not wanna empty urine with a PureWick. There's all kinds of things you've gotta think about before you send a patient home. Spastic bladders, on the other hand, have some tone. There is still that autonomic reflex that's intact, that just goes to the spine, but it can't go up the spine anyplace. So with a spastic bladder, and the way we know it's a spastic bladder is that the patient has periods where they are dry. They're dry, and then you check and they're wet. So that means urine's been collected in the bladder, and then what happens is, rather than being able to control that sphincter, all of a sudden it just opens, and all the urine comes out. We can train that bladder. And you can train it two ways. You can train it just to respond to a Valsalva maneuver, utilizing time or amount of fluid. So in other words, you can train the bladder to release and open the sphincter when the patient performs a Valsalva maneuver every 4 hours, every 2 hours, every whatever. Some people, after they've mastered the hours, can also do it to the amount of fluid. So once they've had 300 cc's in, they wait a half hour, 40 minutes, and then they will perform the Valsalva, and they will eliminate their bladder. The problem with that is, and there are some problems, but the problem with that, one of the problems is, if they're going to go out into the world, they don't wanna have to be wet by accident, so they will still need to wear some type of undergarment that's gonna prevent them from embarrassing themselves, not necessarily anybody else, but themselves. So that's one way to do it. Another way to do it is with a catheter. Again, there's that dirty word, Foley catheter. And what you do with the Foley catheter is the same thing you would do with the Valsalva. Is you would clamp it, you use a clamp that usually, I don't have a clamp. Every nurse should own a clamp, just FYI. And when you put a clamp on a Foley catheter, it should not go on the catheter itself, because the clamps have teeth, and it will rip the catheter. It should go on the tubing. If you don't have a clamp, you can take a rubber band, bend the tubing, rubber band it, and stop it. And then periodically, at distinct times, you open it and you let the urine out. What that does is, it's muscle memory. You all know about muscle memory, right? Muscles actually have memory cells in them, and they remember past experiences. So once you train a muscle, it will do that. So you can, again, train it to time, or you can train it to amount of fluid. And you can, the last thing that has to happen is, you do need to teach patients how to catheterize themselves in the event that they would need to. And believe it or not, people teach both men and women to self-catheterize. Easier in men than women, but still can be done. Because the other thing you want to do is you want them to have as normal a life as possible, right? If they're paraplegic or quadriplegic, they're still gonna want to go out with their friends, they wanna, because we did forget to talk about that, we'll talk about that in a minute. They wanna continue their lives to the best of their ability, so they can put a catheter in, they can put a leg bag on, and then they don't have to worry about accidents while they're out having fun. And then they can go home and start all over. It doesn't eliminate the good work that's done when you train a bladder. So you can train a bladder. What I said we forgot to talk about is who gets spinal cord injuries? Who's at highest risk for spinal cord injuries? Children and gymnasts in particular. I'm thinking who else? Not all, certainly elderly can have it, but you know who's at absolute highest risk in terms of numbers? Young adult men. Because young adult men, remember I said earlier, our brains don't grow until they're 27? Well, girls' brains grow a little faster. No, this is just biology. We know this. And men, young men, tend not to mature as quickly because their brains have not completed growing yet. So young adult men are usually much bigger risk takers than other age groups. So they're the ones like jumping off roofs. They're the ones who decide they're gonna, drive 90 miles an hour down the road on a motorcycle without a helmet. They're the ones who are doing those types of things. They have found that the girls' numbers are going up as women as there's more equality in what women do, young women and young men, but the numbers are still pretty significant that it's young adult men. My son, who is of my 3 children, the most logical, the most by the book kid. Like he was a kid at the age of 8 who would come home and say, I have to do my homework first because I have soccer practice. And I would say to him, no, you have to go out and play. He'd say, no, I have to do my homework. Same child who was in college and called me from the library on a Saturday night. I never thought in my life I would tell my children to close the book and go out and drink, except for this one. I was like, could you close the book and go out and have some fun? So this is my child. And then, I don't know, about 2 years ago, I think it was, we were looking through pictures of something, and there was a picture of him jumping off a cliff into rocks. I said to him, is that you? Because next to him was the kid who was on my roof. I knew who that was. He said, yeah, that's me. I said, because that's Kevin. So, is that you? He's like, yeah. I said, when was that? Oh, in high school one day we took off and went up to the reservation and just decided to jump off the cliffs. And he's the logical one. So if he's doing it, we know everybody's doing it. I almost died. I was like, that's a good thing I did. So many things I don't want to know. Like, just don't tell me. I'm much better when I don't know. So,
My mother also did.
because of the fact that we are talking about young adult men, when we talk about things like what we're going to do to help them move forward, we have to understand we want their lives to continue as normally as they possibly can. So, back to content. Okay, bowel dysfunction. The goal is to empty the rectum. Simple, seems like a simple goal. The problems are, however, constipation, impaction, and a paralytic ileus. Constipation is usually twofold. It's hard stool, as well as not having a bowel movement with the regularity that your body usually does, right? Not everybody goes to the bathroom and has a bowel movement every day. But if normally you go every day, and now you go for 4 days, we would call you constipated. Impaction is a little bit different. Impaction is when the stool is rock hard. And there's no lubrication within the rectum or in the lower colon, and it cannot be evacuated, except to do it manually. And In the state of New Jersey, you may not, as a nurse, manually disimpact somebody. Who does it? Doctor. Why? Yes, that's correct. Why? I'll tell you my favorite day of the year. Why do nurses, is it really hard to disimpact a patient? I can tell you from experience, the answer is no. Not hard. But what can happen? Two things. They can have a vasovagal reaction because the vagal nerve is right there, and they can go out on you. And the second thing, which is much more serious, is the stool is so hard, you can perforate the rectum while you're trying to pull it out, literally. So if somebody's gonna do that, for some reason, they'd much rather have it be a physician, I'm really okay with that. Not that I have not disimpacted patients, because I have. Not in New Jersey, when I worked in New York. But one of my very favorite days of the year is July 1st. It's also my least favorite day, because that's when all the residents and the medical students go to the next level. So medical students become doctors, they think, and interns, then medical students become interns and residents. And then they really think they know what they're doing, they still have no idea. That being said, I love it when it happens to be July 1st and a patient needs to be impacted, and I can hand a new physician a pair of gloves, and their look on their face is like, yep, this is your job. And they say to you, I don't think so. And you say, I know it is. Hey, why? And gloves. Bye. Okay? But I never want to be in the hospital on July 1st. I will stay home with a hot appendectomy before I went to the hospital on July 1st. Never. Paralytic ileus is when the gut shuts down. And it could shut down because of an impaction or constipation, or it can shut down because the nerves to the gut are damaged with the spinal cord injury. That's a more long-term problem. Oftentimes, it doesn't last long. If there's that cord edema, where there's a shutdown, it will definitely last that long. But it's a problem. If it's going to be long-term, then they're gonna have to be a lot of different interventions to keep that gut open and moving, okay? Bowel training is much easier than bladder training. We are all bowel trained. Our mothers did a very nice job. When you potty train a child and you teach them how to use a toilet instead of a diaper, you are in effect bowel training that child. Because you're teaching them that when they sit on the toilet, they go to the bathroom and they have bowel movement. It's really not much different. It's repetitious at the same time of day. So you would either put the patient on a commode, on a bedpan, which is the least comfortable. If you can get them to a bathroom and sit them on a toilet, that's optimal, at the same time of day. And that time of day should really depend on when the patient had bowel movements prior to having a spinal cord injury. Some people have bowel movements first thing in the morning, some people need 2 cups of coffee and a cigarette. Please, let's leave out the cigarette these days. Some people, it's at night after dinner, right? We're all bowel trained, and it usually had to do with something with our mother saying to us, you know, you have to poop before you go to school, or you have to poop before you go to bed. Whatever it was in your family. And so we're all bowel trained. And that's what we want to do with our patients. Now, for some of them, especially who have either a full paralytic ileus or a very slow gut, they may need things like Colace, they certainly need fluids. They can't get that much in terms of exercise, right? Because they're paralyzed. So just moving them up and down in bed might help. Their diet needs to be appropriate. Those types of things we need to think about. And then we need, some of them might need a fleet enema to get them going. And then we need to stick to that schedule. When, years ago, we used to take students, I think some of you, do some of you still go to a nursing home in level 1? No, nobody, okay. In the olden days, I'm really dating myself, the first 3 weeks of level 1 clinical were always in a nursing home. It was just to get people meaning you, students, used to touching patients, washing them, talking to them, seeing and smelling things that are not normal. And the nursing home I went to, and I have to tell you, I hated it. I hated every moment of every week that I spent there for all those years. I just didn't like it. Not because I liked the residents, I didn't like that the nursing assistants were like so territorial that they wouldn't let the students do anything. Like, this is not good. Anyway, every day that we were there, at 11 o'clock, this song would go on the overhead. Finally, about 3 years in, so, I'm there twice a week for 3 weeks for like 3 years. About the third year, I finally said to the nurse, "What the hell is with that damn song?" And she said to me, "That's our bowel training program." I said, "What?" She said, "That's our bowel training program." She said, "Wait, watch." Sure enough, and I had never noticed it. Every resident that could walk was like on their way to their room. Every patient in a wheelchair was calling for their aid, "Maria!" And they were being every patient in their room was being toileted. Every single patient. They had no impactions, they had very little stool incontinence, and they never had a paralytic ileus due to constipation or anything. It was unbelievable. There were 120 residents on that unit. Broken up into 2 halves, 60 on one, 60 on the other. It was gigantic place. Every single one, except if they were like, totally bedridden and not alert, but every alert patient. And then you'd hear all the toilets flushing, flush. Never noticed that before. It was just the damn song that drove me crazy. She told me that within 2 weeks of arrival on that floor, they were all bowel trained, every single patient. From when they came, 2 weeks later, it was just part of their routine. So it's certainly doable. They did it on a very large scale, so it's certainly doable on a small scale. But the other important thing to remember is if a patient is on a bowel regimen, we should try our very best to keep them on it. And that's a little harder now with the computers. In the old days, you could schedule meds whenever you wanted, but I would still say to make an effort if you had a patient we had a patient once, and the staff said to me, "Don't give him to a patient, he is so nasty." I mean, don't give him to a student, so of course I gave a student. Well, you have to learn how to deal with nasty people. That's just, and better to do it when you have some support than when you're all alone. So I sent the student off. She's like, "Do I have to?" "Yes, you have to go in." And within just like 15 minutes, she came out to me and she said to me, "You know why he's so mad?" And I said, "Why?" She said, "Because he's constipated." And I said, "Okay. And how is that anybody's fault that he's so angry?" And she said, "Because he told them that he had a routine. And he told them what it was. And they didn't do it. And now, after being there for 3 days, being off his routine, he was constipated, he was miserable. And it would not have taken that much time and effort to do it. Instead, he was a miserable human being because they did it to him, and then they were mad at him because he was a miserable human being. And it wasn't that hard. Instead of they were giving him his Colace with his 8 o'clock meds. He always took his Colace at 11. He took a half a bottle of mag citrate, and then he needed to sit on the toilet at 4 o'clock. That's not that hard. I mean, he wasn't asked to be, you know, hung from the ceiling. He was asking for simple things. And they actually said to him, I'm sorry, we can't accommodate that. Why? Why can't you accommodate that? That, again, not hanging from the ceiling. He was otherwise totally independent. He did his own care, he got in and out of his wheelchair, he went to the bathroom by himself, he needed no assistance from us. He had a wound infection, that's what he was there for, because he had poor peripheral circulation. He needed nothing from us except to stick to that routine. And somehow we just couldn't manage to do that. So if you talk to people and you find out what the problem is, usually it's pretty fixable. I mean, you can't fix everything, but, so I went out and I said to the nurse, you know what he wants, right? She said, no. I said, he wants to be put back on his own bowel regimen. Oh, why didn't he say it? He did. And you, somebody, not you maybe, but somebody told him, no, I'm sorry, we can't do that. And he ended up being there, because he ended up having a skin graft on his wound. He ended up being there for, I don't know, almost 7 weeks, because it wasn't doing well. And he was fine. Gave him his Colace when he wanted it, gave him his half a bottle of Mag Citrate, and sat him on the toilet. He was the model patient. All we have to do is talk to them. Think about how you would feel if you were in a bed and all you needed were a few things that you had no control over. I hate having no control over anything. I like my life in order. Okay, onward. All right, so some general interventions, we already talked about some of them specifics. We want to make sure that we provide the patient privacy, that their fluid and their diet is appropriate, that their activity level is as much as they can tolerate. And that should build over time. You know, they should be able to, if they have a spinal cord injury, get themselves from their bed to their chair. They should be able to lift up to put a bedpan under them if they need it, those kinds of things. Catheterizations if necessary. Medications. Most medications for spinal cord injuries have to do with initially for an atonic bladder, there's really not much we can do other than try to keep the urine acidic, and we keep the urine acidic with vitamin C. Because why?
Few bacteria.
Right, bacteria doesn't like acid, so it's not gonna grow, so we wanna keep it. But for the spastic diet, we can also give those new bladder antispasmodics, like, what's that one with that little bladder that walks around? I can't think of it. But also, like Ditropan is one, that's for bladder spasms. We definitely wanna do the vitamin C, we wanna make sure that that is also acidic, because that is gonna be sitting for a while, it's not just gonna be falling out. And for the bowel, the medications are gonna be Colace. There's also, now what's Colace? Softener. It is not a cathartic, it's not going to increase peristalsis to help them go. There is a Colace that comes with that's a combo drug. And sometimes just a soft stool is not enough. They need a little help in moving the peristalsis along. But they could need some Mag Citrate. Sometimes, Mag Citrate's pretty harsh. So sometimes just giving magnesium pills, if their magnesium level in their blood is not too high, you can just give magnesium pills and they can help. Milk of magnesia, that's the whole point behind milk of magnesia. And then last but not least, disinfection for the bowel. That is just to be assigned to somebody. cranberry pills. You don't wanna give them cranberry juice necessarily, cause that's also very acidic. But you don't wanna give them cranberry juice, cause cranberry juice is basically sugar with a little bit of cranberry. So, but the cranberry pills can be pretty effective. Those are good for UTIs as well. Okay, so when we talk about rehabilitation of patients with spinal cord injuries, we need to know the extent of the lesion, meaning the extent of the damage, where, how big on the cord is it, the level and the location of the lesion. So not just how big is it, but where is it? The age and the health history of the patient can often, not interfere, that's the wrong word, can also help determine how a patient does with a spinal cord injury. And I already told you, it's young adult men, and that were the primary group of people. But looking at the age of a patient, if they haven't had anything before this that's been monumental, we may not know what their coping is, and they may not be good copers. So sometimes younger patients, have had a very hard life, and then they have something like this, and it's seen as just another thing that they've gotta get over. So knowing the age and the health history of the patient can be helpful. The other thing is, that I just alluded to, is the emotional makeup. Are these people, is this patient, a half empty glass person or a half full kind of person? And it really makes a difference. Are they optimistic in general, or are they pessimistic in general? We had a teacher at my kid's high school who talked to every incoming freshman class. He was quadriplegic. He had 2 fingers. When we first met him, he had a whole hand that worked. By the time my youngest got to the high school, he only had 2 fingers that worked. And he had a motorized wheelchair, and he would tell the kids the story. He was 16 or 17, he was in a car full of kids. They were all piled in. They were all drinking, driver was drunk. They slammed into, I think, a tree, what he said. And cause he would say to them, this wasn't my plan for my life. I wasn't gonna be a teacher. I had a whole different plan, and I had to make a choice whether or not I was going to continue to live and live a productive life, or if I was going to be angry and ruin the rest of my life. And it was a very sobering talk, and the kids are all like, they're 14 and they're like, eyeballs are this big. And then 2 years later, they're all in the same car drinking. But anyway, he clearly was a person who had a positive thought process and was able to cope. But he told the kids how hard it was that for the first 2 years, he did nothing. He wouldn't leave his house. He wouldn't see people. He wouldn't even, his father, he said, my father would pick me up and put me in my wheelchair because he would not want to get out of bed. And he would physically put him in his wheelchair and make him get out of bed. He said, and then I decided, he said, I realized that 2 years in, that this was it, that I had to make a decision, and was I going to, just ruin the rest of my life, or was I gonna try to do something different? He went back to school, he got a teaching certificate, he taught history for years, and then he went back and got a second master's in guidance counselor, and he was a guidance counselor. So, emotional makeup and coping strategies can be really, really important for people, and being able to support them, to help them find, they may not have ever had to deal with anything like this, so it's always good to help them find people who can help them to come to terms with it. What kind of support systems, and not just familial. Support systems like, do you have enough money to put a ramp in your house? Do you live in a house that has doorways? I live in a house that was made born. My house was born in 1912. My doorways do not fit wheelchairs in the old the older part of the house. There is no way I would have been able to have a wheelchair in that house. So, what kind of support do you have, and can you have? Can your family move? Do you have to move out on your own? Do you have finances? Can you go back to school? Like, do you have the money to do that? All kinds of things crop up. So just things to think about in terms of support. It's not just familial and friendship support. And then the avoidance of complications. What are we going to do to avoid complications? The best thing we can do is teach our patients to take care of themselves. So we need to teach them about coughing and deep breathing and make sure that they're getting as much movement as possible so that their lungs, they don't get infection. We need to teach them to scoot around in their wheelchair because they can't feel when the pressure is too much on one side or the other, and then they get pressure ulcers. Even people with the best hair in the universe can get pressure ulcers. Christopher Reeve, you all know Christopher Reeve? Christopher Reeve was an actor, he was Superman. And he also did horses. He didn't do horses. He rode horses and he competed, and he was competing and he had a C4 fracture. And he was quadriplegic, and he was respirator bound, and he was very young, like in his 40s. And he learned to talk with the air gulping. But you know what he died of? He died of sepsis from multiple pressure ulcers. He had all the money in the world, he had every single resource. Now, he lived for a very long time as a quadriplegic, very, very long. But even with 24-hour care, the best that money could buy, the best nutrition you could have, and he still died from sepsis or pressure ulcers. So, we need to, as long as we can, avoid whatever complications we can for these people. And the best way to do that is to teach them how to take care of themselves. And to make sure they have enough support and the emotional capacity to be able to do that. His son is now a reporter at Channel 7. Actually, tragic family, then his wife died of breast cancer. Well, no, lung cancer, and she was a non-smoker. Non-smoker, died of lung cancer in her 50s. So, ongoing needs. Educational, I just talked about. OT and PT, because if they're paraplegic, they may still need some help with OT kinds of things. PT would be to help to restore some of the muscle function and to make sure that the joints are staying as supple as possible, and also to make sure their upper body, if they're paraplegic, that they have strength in their upper body, in and out of the wheelchair, those kinds of things. I told you once again, we would talk about sexuality, and here we are, sexuality counseling. I just said young adult men. We cannot ignore, and we cannot expect that patients who have spinal cord injuries at the age of 18, 19, 20, 30 are never going to have sexual activity. It's not reasonable that we just ignore it. So getting them into some kind of sexuality counseling, getting them some understanding of how their body works, because oftentimes they don't even know, it just kind of works. And then making sure that if they have a partner at the time, that the partner is included. If they don't have a partner yet and they're not even thinking about it, then leave them open to the idea that when you get a partner, you may want to re-examine this area of your life, because it might be important to a partner. So, we want to think about medical resources. This is a lifelong event. It's an event, but the repercussions are lifelong. So what kind of medical resources do they have? What kind of financial resources do they have? And then finally, psychosocial support for everybody. We had a young man in town who was fooling around with his younger cousins, dove into a wave as the wave was coming, thought it was deeper, C-grade fracture, and he was a quadriplegic, and he was 18. It's a long life ahead. So knowing, helping patients to become more intact with who they now are and their new image of who they need to be can be very, very difficult. But it's part of what we do, it's part of our job. And they may not be ready when we see them, but we can always give them information, we can write it down, let them take it with them, and when they're ready, it'll be there. Or hopefully they'll have somebody else in their life who could do it. The last thing we're gonna talk about is, maybe not the last thing, last thing, with spinal cord injuries is autonomic hyper or dysreflexia. It is also something that occurs at T6 or higher injuries. And it's an exaggerated sympathetic response in patients with injuries at T6 or higher. So sympathetic nervous system. And it's, you need, for this to occur, you need a stimulus, and then you need a reaction. And this only happens after spinal shock. So a patient has spinal shock, and then they're at risk for this happening. The stimulus, we said earlier, and I think it can't go up the cord. Just, it can't go up, because now there's this break somewhere in between. So because the because the messages can't go all the way up and down and communicate with each other, you get a response that's abnormal. So what you get is vasoconstriction below the injury. So if your injury is at T6, because the first starts, T6. Anything below the injury is gonna constrict. When the stimulus occurs, not automatically, not anytime willy-nilly. When there is the stimulus, there is vasoconstriction below the injury and vasodilation above the injury. There are 3 big stimuli. It can be anything, but there are 3 biggies. The first one is a distended bladder. The second one is an impacted rectum. And the third is irritation of the skin. So, another good reason for the bladder not to be full and for the patient not to be impacted. Because we'll see the symptoms in a minute. But the skin is a little bit different. The skin can sometimes be something as minor as the sheets on the bed are heavy. Like they've got a sheet and they've got a blanket, and laying on these legs that are not moving, that irritates the skin, and that can set this off. And the only time I ever saw it happen was with a patient who had a spinal tumor, and he was young, and he had a crush on the physical therapist, and he was going down to physical therapy, and he wanted his jeans on. And being the good little nurse that I was like, okay, I'll put your jeans on. And as I'm pulling his jeans up his legs that don't work, he says to me, I don't feel very good. I look up, he is beet red. His veins are bursting out of his neck. And I'm standing there like a nincompoop, just like looking at him. I had no idea. I did not know what it was. I didn't know what to do with it. I yelled out the door, I need some help. Thank God, the nursing assistant came. Not a nurse, a nursing assistant. And she said to me, get those pants off him. I'm like, okay. Pants came off. It didn't stop him. He needed medication. And she got a blood pressure machine. She got a blood pressure machine. In the old days, like a real one, like we had to pump it up. His blood pressure was 200 over 110. So, it's a medical emergency. This is one of the few things that if you see it on NCLEX and it says call the doctor, you have to call the doctor. That's your first thing, call the doctor.
Doctor, would you do two different blood pressures, like one on the thigh, because it's like below the injury?
No, you would just do it, a regular blood pressure on the arm
Okay.
is enough to do it. And, but you would, as you're calling the doctor and yelling for help, you will be, if there's a Foley, you check the Foley. You also, that's the other, you know, like we do these things routinely, we don't think about them. You know, you always ask in the morning, did he have a bowel movement? Well, that's what, one of the, you know, with a spinal cord injury patient, that's one of the reasons we ask. Because if they haven't, we should have addressed it before this, because I don't know how many days he hasn't gone and nobody's really checked, and now he's gonna have a dysreflective reaction to it. And it is a medical emergency, they can die. So, blood pressure, know if your patient's had a bowel movement. If there's a Foley catheter, check to see if it's kinked or clogged or whatever, if they're sitting on it. Or, and then feel their bladder to see if it's distended, you may have to put a Foley catheter in to get the urine out. So those are your first three things that you have to do, but you must call a physician, because they need IV blood pressure medication. So hypertension, bradycardia, headache, throbbing, explosive. That's what he said to me. He said, my head is going to explode. I kept thinking to myself, oh God, I hope not. Nasal congestion, facial flushing, and diaphoresis, soaking wet. It's very distinct. And I have an article, but I didn't get it copied, so it's very short, it's like 2 pages. That's very nice explanation of the whole pathophysiology of it. So I will copy it today with a huge mark. Okay? All right. I'm listening.
Doctor, I have a question about vasodilation about the injury while the patient is having hypertension. How does it correlate with that?
With what other patient, I'm sorry?
Well, when the patient has a vasodilation about the injury and then getting the blood pressure to the,
That's spinal shock. This happens after spinal shock, and you need a stimulus. Something has to happen to make this happen. The other one is due to the injury itself. The spinal shock occurs within the first 24 to 48 hours because of the injury itself, okay?